Now, one thing that has, again, been a very exciting space in the last year itself has been accelerated approval of Tarlatamab, which is a bispecific T-cell engager, which is why I've titled this slide as Taking a Bite at Small Cell Lung Cancer. What are bispecific T-cell engagers? So shown here in the figure, in figure A, you have the tumor cells, which have a protein called delta-like ligand 3, DLL3. And this bispecific T-cell engager, shown here as the antibody, has two binding arms. One binds to CD3, which is a receptor on the T cells. The other binds to this DLL3 on the blue arm, which is the arm that binds to DLL3 protein on the small cell lung cancer. What it does is, when this antibody binds, or bispecific T-cell engager binds to DLL3 and CD3, it brings the T cell close to the tumor cell. The T cell gets activated, releases certain substances called granzymes or perforins. These are proteins that help kill the small cell lung cancer, cause cell death. And the way the BiTE or bispecific T-cell engagers are structured, they generally have a domain that binds to a cell surface protein, and the other domain that binds to CD3, and also has a tail. We call it the silenced FC domain, which helps enable this antibody to have an extended half-life so that it can remain in the system and kill tumor cells. What is the data for Tarlatamab? So 2023, we had this clinical trial that was presented, published, called the Phase 2 Delphi study. And it compared two different doses for Tarlatamab, 10 milligram, 100 milligram. But in summary, what they showed was there was impressive response rate, second line and beyond patients, response rate around 40%, but more importantly, a disease control rate of around 70%, as you see here in the spider plot on the right, where you see these green lines being patients' tumors that had either a complete response or partial response, and they maintain that below the 30% threshold, which is the threshold for a partial response. And the main this phase of maintaining the response continues, which is called durability. The median duration of response in this updated data that was presented last year by Dr. Jacob Sands was around 9.5 months, with a very promising median overall survival of around 15 months, where around 57% of patients were still alive at the 12-month mark. And based on these data, there was an accelerated approval that FDA provided in May of 2024 for Tarlatamab for extensive stage small cell lung cancer, where patients have progressed on or after platinum-based chemotherapy. So we currently use it in the clinic. It's a very exciting time because this is a new therapy. One important thing to understand for this therapy is first couple of cycles do have to be given inpatient because of high risk for two important toxicities that are shown here in the slide. One is called cytokine release syndrome, where there's a lot of different proteins that are released. Something similar to when you may have a really bad flu or viral infection, where the symptoms can range from mild fatigue to hypotension, blood pressure is going low, rash, myalgias, and we have certain approaches to manage these toxicities. Or some of the more uncommon toxicities that we've seen in the trial called ICANS, or immune effector cell-associated neurotoxicity syndrome, because these DLL3 bites can cause inflammation. Inflammation can spread to the lining of the brain, to the brain cells itself, can present as headache, confusion, delirium, and more interestingly as tremors or motor dysfunction. And there are certain approaches, especially with steroids, to manage these side effects. And both of these side effects tend to happen generally within the first couple of treatments of Tarlatamab, which is why the general recommendations are to start treatment inpatient. But there are some centers where they have tried to slowly transition Tarlatamab to the outpatient setting. So what we have done for our patients is we still currently at the University of Oklahoma, we do inpatient for the first 2 cycles. If the patient does okay, because it's a step-up dosing, then we transition them to the outpatient setting. And if the patient is being referred from a community oncologist where they may not have the capability of giving inpatient Tarlatamab, we see the patient at our facility get them the first couple of doses inpatient, and then help the patient transition back to their community oncologist if the community oncologist lives closer to home, which is important because we want to make sure that the patients don't have to spend a lot of travel time coming for each outpatient cycle, which is what we do after the patient's first couple of treatments are finished. Then it's all outpatient.